Hello friends, in this video I'll be demonstrating you a case of white cataract in which I'll be doing a double rhexis technique. Let's see how we proceed. So this was a case in which the pupil was, I would say, non-optimally dilated, was around 7 mm, which is more than sufficient to do any such cases. And AC was shallow, I would say that. And it was a white cataract. It was pretty intumescent. The anterior capsule was very tense. So by this time, I've already made the two side ports and I'm instilling some phenocane to achieve whatever kind of intracameral anesthesia and dilatation is possible. And now, in this case, I'll also be doing some staining of anterior capsule with trypan blue dye because this is a white cataract and there is no red glow present in this case. So it's always better to dye it and generally in these cases what I do is either I dye it twice or I leave the dye for at least 20-second period and I time it. I time it with a clock that I leave it for 20 seconds and that's how it goes. It stains the entire capsule very nicely and because what happens that when we do double rhexis technique, then we need to wash the cortical matter. And during that washing, a lot of dye gets washed out from the entire capsule. So if it is not brilliantly stained or nicely stained, then that can cause a bit trouble. So now after staining and refilling the AC with visco, I make my main port, which is temporarily at 180 degree, and I refill my AC with visco and I coat my epithelium with visco. Now you can see I'll nick the anterior capsule with 26 gauge needle to and then I will use 23 gauge microcapsulorhexis forceps to complete the microrhexis. This microrhexis, what it does, it creates an opening in the anterior capsule through which the decompression of the nucleus can be done. And we can use any kind of methods. Either we can use irrigation and aspiration method, we can use churning. What I do, I use my hydro cannula and I just flush the bag with fluid. And what it does, it decompresses the bag very nicely. And with that, the intralenticulaire pressure decreases, and then I'll be able to complete my second rhexis. But before that, what is most important is when the this thing capsule is very tense, then we need to complete our first rhexis, that is microrhexis. That is one of the most important. But I feel in any kind of white cataract which are intumescent, that if we are able to make our first rhexis, that is microrhexis nicely, then generally that heralds the way for a good cataract case. But if we are not able to do that, or if we get a lot of trouble in making that, then trouble can ensue. So now, in this case, I've already made the small rhexis, and I'll be using my hydro cannula to decompress the bag. As you can see, while I'm irrigating the bag with small aliquots of the fluid, then a lot of white cortical matter is coming out of it, and that is leading to decompression of the bag. And what will happen at the end of this decompression procedure is that only the nuclear material will remain, that is, the nucleus will remain inside the bag, and the bag will be more or less empty, and that will reduce the interlenticular pressure and making the second rhexis, that is larger rhexis, would be a piece of cake. It's very simple to do. So now what I do, I take a micro rhexis forceps to make a neck which will be tangential neck at the capsular margin in the smaller rhexis, and then I'll take a microcapsular rhexis forceps, which is 23 gauge forceps, to make the larger rhexis. Because we have to make two rhexis in these cases, that's why we call it a double rhexis technique. What are very important instrument in such cases is basically any kind of good utrata or rhexis forceps and any good Caesar to give nick to the capsular margin. If we have these two things, then we can proceed with this case. And basically, I am practiced with microcapsulexis forceps and scissor, so I use that. Otherwise, it's not very difficult to do these cases with Pana scissors and Utrata forceps. That's pretty simple to do. Now, because my rhexis is complete. So what we say that once your rhexis is complete in a case of white cataract, then your case is almost over. So in this case, again, I'll be employing my favorite technique, nucleus disassembly, that is horizontal chop technique. And you can see I held the nucleus with vacuum, with bevel up, and I use my ball tip chopper, which is 2 mm, to create a crack in the nucleus. And I'm doing multiple pieces in the nucleus first, and I haven't started engulfing it, because what happens that each piece of the white nucleus bears down onto the posterior capsule, and that makes uh, the surgery safer. And with that thing, what happens that the piece is protected nicely with the pieces itself. And you can see now my side instrument, that is my 2 mm ball chopper, is just acting as a PC protector. My phaco probe is remaining in center, and I am able to complete the nucleus disassembly very easily. Now you can see that only some wispy cortex material is remaining. Otherwise, the bag is pretty clean. And this clean bag occurs because before doing the nucleus disassembly, I have done a lot of hydro dissection using my hydro cannula to decompress the nucleus. At that time itself, a lot of cortical material gets dislodged from the capsular bag, and it becomes very clean. Now, what I'm doing, I'm the cleaning the bag. The bag is now clean, and now I can go ahead with the implantation of hydrophobic foldable lens. And now I'm demonstrating how to load a hydrophobic foldable lens, which has a C loop haptic in a butterfly cartridge. You can see, just put that optic and haptic behind the wall and fold it nicely. Check it and load it. Just see, if you inject the cartridge, then it should go smooth. In case that happens, that means that you have loaded the cartridge very nicely. It's not at all difficult. You need to load it once or twice, and you'll be able to learn it. Many a times what happens that these two haptics can remain stuck. You don't have to be worried about it, because this is a very common occurrence and it can happen. And while you take your irrigation aspiration cannula to do the IA, at that time you can use these two things, these two haptics which are at namaste position, to dislodge them. Now, at the end of the surgery, I have cleaned my AC, I have removed all the visco from the anterior chamber, and I am closing the side port first, and I'm making the AC now. Now, because this was a white cataract pertains to intumescent one, so what I do, I put a small amount of triamcinolone acetate, which is diluted 1:5, and then I wash my AC. It gives me a very clean and very quiet AC next morning. Sometimes it can cause IOP rise, but it's not a dictum. Sometimes it causes, most of the time, the IOP remains normal. You just may have to make sure that you wash the AC nicely after you put triamcinolone acetonide in the AC. Now it's time to close the case, and the case looks very clean. This patient performed very well at the end of the surgery. I don't have the post-op pictures of this case, but this case really did very well. You can see that I'm just trying to make the eyeball tight, and you have to make sure of one thing, that the eye should be watertight, not just airtight. Now check the intraocular pressure at the end, and The case is closed now. Thank you, guys. Thank you very much. In case you have any queries regarding white cataract in which the double rhexis technique is required, please do comment. Thank you. Thanks a ton.